Thank you to the team at LBBC for inviting me here this afternoon, and thank you to all of you for sharing the next hour with me as we go through this very important topic of understanding testing in breast cancer. But as we all know, anyone can develop breast cancer. 1 in 8 women will get breast cancer in her lifetime. And although much less frequently affected, men can also develop breast cancer. So the good news we'll start with is that trends in female breast cancer death rates are falling, and they're pretty consistently falling. Now, this slide actually shows the death rates by race and ethnicity, and recognizing that there are clear disparities in care, and Black women especially are at a higher risk of dying of breast cancer, as we know that these disparities are very important to address. What I would like to focus on is a bit of good news in that the overall rate in 2020 declined by 43% from its peak in 1989. And that equates to a considerable number of breast cancer deaths that have been averted. So how are we making this progress? Well, a lot of the progress has been made on the basis of getting the word out about the importance of early detection, finding cancers at a smaller size and without lymph node involvement, or finding stage 1 and earlier stage 2 cancers. It definitely equates to improved outcomes and increased chance of cure. But also, these improvements in death rates are very much the result of improvements in our therapies. And our therapies are very much based on a lot of the testing that we put patients through and tumors through. And that's what I want to focus on today. So again, just by way of background, I just want to share this news that for early stage localized cancers, the overall 5-year survival rate is very high, 99%. For regional cancers, meaning larger tumors with lymph node involvement, we're still making considerable progress, but again, finding these cancers at a smaller stage or earlier stage very much links to improved outcomes. So now let's focus on treatment and talk about testing, but first let's talk about the therapies that may be offered on the basis of some of the testing that I'll be reviewing with you today. Well, treatment is based on the type of breast cancer and its stage. Of course, we take into account your overall health, menopause status, and personal preferences are, of course, considered. Many times in the early stage setting, we're including local treatments such as surgery and radiation as part of the therapy. It's not an absolute that those treatments are not part of a treatment plan for a stage 4 or metastatic breast cancer patient, but more often the therapies in the metastatic setting focus on systemic treatments such as chemotherapy, hormonal therapy, targeted drug therapy, and immunotherapy. And as a medical oncologist, my focus is in giving these systemic treatments to either stage 4 breast cancer patients, or also in certain situations to high risk early stage breast cancer patients in an attempt to reduce the risk of recurrence. So now let's get into the topic at hand, testing. And let's talk first about the different types of testing that you may be offered during your treatment journey. Well, in the beginning, we often do baseline blood work to assess kidney and liver function and monitor blood counts as well as side effects. We can use the blood work to monitor side effects and organ function. And then, of course, imaging tests are very important, like CT scans, MRIs, PET scans, and bone scans to track response to treatment and detect progression. This is most used in the metastatic setting, but even for early stage patients when we're trying to understand whether the cancer may have spread up front at initial diagnosis, there may be an indication to do some of these tests. Many of our, or I should say some of our medications can cause side effects, especially with regards to the heart. And that's why there may be the need for an EKG or an echo. Those are cardiac monitoring tests. And then there are opportunities to do other sorts of specialized tests called liquid biopsies, where we're tracking in the bloodstream fragments of DNA, circulating tumor DNA that has been released into the bloodstream, and we're identifying on those blood tests mutations that may be present in the cancer that could help us track treatment response. And again, that's very much utilized in the metastatic setting. Genomic profiling is an important aspect of treatment, where genes are analyzed in the tumor as well as proteins to identify specific mutations, which may be targeted. And then, of course, tissue biopsies are very important to analyze not only mutations that evolve that may impact treatment, but baseline tests on those tissue biopsies. For example, we'll go through in the next slide, one of the major factors that we use to inform what we offer in terms of early stage and metastatic treatment, but that's based on the subtype of breast cancer. Again, this is based on a tissue tumor biopsy. Now, broadly speaking, in the early stage setting, we're thinking still of our breast cancer diagnoses as one of 3 subtypes, and recognize that breast cancer is not one disease. There are multiple subtypes. The most common is hormone receptor positive breast cancer. And I'll be focusing a lot of my discussions when we come to testing on this subtype of breast cancer, but recognize that about 10 to 20% of breast cancers are so-called HER2 positive. These tumors depend on this gene HER2 to grow, and it is a somewhat more aggressive subtype of breast cancer. But the good news is we've made considerable progress in treating this subtype, and we've improved outcomes greatly. A lot of the declining death rates for breast cancer have been attributed to our improvements in treating HER2 positive disease. And then triple negative breast cancer, meaning these tumors do not depend on estrogen or progesterone or the HER2 gene. So those are 3 negatives. We call that triple negative breast cancer, accounting for a smaller minority of breast cancers, but tend to happen more often in younger women and particularly Black and Hispanic women. So in the early stage setting, when you have a breast cancer diagnosis, one of the first things to try to get a sense of is which subtype of these breast cancers do you have, and that can be reviewed with your oncologist or your surgeon based on a pathology report. So now let's dive into this a little bit deeper. A lot of people get confused about this terminology, hormone receptor and estrogen receptor. Hormone receptor positive is a broader term, but it encompasses ER positive or PR positive. Tumors can be ER and PR positive. They can be ER positive and PR negative. Very infrequently, they can be ER negative and PR positive. But if either of these 2 receptors are positive, we call it a hormone receptor positive tumor, which means that the cells have receptors for the hormones estrogen and progesterone, and it means that the cancer can be stimulated to grow by these hormones. About 2/3 of all breast cancers are hormone receptor positive. So very much the most common type. Now, what about HER2? Well, we're going to talk about HER2 a lot, especially when we get to the metastatic setting. We're going to circle back with this new term called HER2 low disease. But in the early stage setting, we're not utilizing HER2 low status very much. We're still considering tumors HER2 positive or HER2 negative in the early stage setting. So what is HER2? HER2 is a protein that's located on the cell surface, and it's involved in normal cell growth and development. and an overexpression of this protein on cancer cells leads to aggressive tumor growth. Now you see a normal cell on the left, normal HER2 expression. All the way on the right, you see what we call a HER2 3+ tumor. That's moderate to high HER2 protein expression. And then there is a continuum, 0, 1+, and 2+. Now, the 2+ is considered indeterminate, and additional testing needs to be done to identify whether that tumor is HER2 positive or not. But generally speaking, HER2 1+ and 0 is considered HER2 negative in the early stage setting, and 2+ with that additional testing could either be HER2 positive or HER2 negative. Now we're talking about testing, and so far we've talked about the importance of ER, PR, and HER2, and recognizing that those markers very much drive the treatments that we can offer. What is an additional piece of testing that is very important, or an aspect of your history, is your family history. So when we think of breast cancer, many of us, I see this or hear this in my practice quite often, that I don't understand how I developed breast cancer. I have no history, no family history. Most women who develop breast cancer don't have what we call a hereditary type of breast cancer that developed because they inherited a gene that was mutated from their mom or their dad. Most are considered what we call sporadic type breast cancers, but about 5 to 10% are on the basis of a gene that was inherited from your mom or your dad, and that gene is mutated. These hereditary breast cancers are associated with younger age at onset, triple negative more frequently, but not always. Even hormone receptor positive, HER2 negative breast cancers can be on the basis of a germline genetic mutation. And it's important because if you harbor one of these additional mutations, there are one of these mutations, there are additional cancers that you may also be at risk for developing. And as I'll show you, it impacts not only how you will be monitored, but now more recently also impacts treatments that you could receive in the early stage as well as metastatic setting. I apologize, I see the slide is a little blurry, but hopefully you can still see it well. There are several genes associated with hereditary breast cancer, and notice a big portion of this pie chart is kind of vague. It says other genes and familial risk factors, and that sort of is alluding to the fact that we don't know the entire story in certain families. I've seen many patients in my practice who have very, very strong and suggestive family histories, and we've not identified which gene may be involved in their specific family. The most common that we see and that we know of that are hereditary gene mutations that can increase the risk of breast cancer are BRCA1 and BRCA2. But as you see, there are a variety of other gene mutations that can inform your risk of developing breast cancer. So let's focus on BRCA a little bit because it is the most common. So what is a BRCA mutation and why does it matter? Well, BRCA genes are found on chromosome 17 or 13, as shown here, BRCA1 and BRCA2. And as we talked about in the first slide, 1 in 8 or around 12% of women will develop breast cancer at some point in her lifetime. You see those risks going up markedly with the presence of a mutated BRCA1 or BRCA2 gene, as shown for you in the left lower hand portion of the slide. So these mutations affect the cell's ability to repair DNA. And if you have this mutation, you have multiple options to reduce your risk of developing a future breast cancer and to decrease your risk of developing other cancers like ovarian cancer. And you see some of those options shown for you here. Most importantly, there's a 50% chance of passing it on. And so you see in the picture on the right in pink, the father in this case is affected. This is, again, another common misconception that only women can have an issue with a mutated BRCA gene. Men can as well, and there's a 50-50 chance. As you see, there's an affected son and an affected daughter in this case on the lower right-hand side. Men are affected and they can develop breast cancer. So if you see a man who has breast cancer, genetic testing is absolutely recommended, but it can also increase the risk of prostate cancer and pancreas cancer. So other breast cancer genes with medical management guidelines are shown here. Again, we focused quite a bit on BRCA1 and 2. I won't take you through all of this right now, but I will show you that the risk that is present with the presence of these genes is variable, as shown for you in this table. There is a different level of data to support preventative surgery, preventatively removing the breasts based on which gene mutation is present. There are guidelines that impact how you should be monitored for developing breast cancer, to include a breast MRI, as well as the traditional monitoring with mammogram every 6 months, and a variable risk of other cancers. So this information is important. I would also add on that now we have the availability of a drug called a PARP inhibitor. It is a pill. If you have a BRCA mutation and you have early stage breast cancer, if your tumor was a certain size and had a certain amount of lymph node involvement, you may be eligible to take that medication, which has significantly shown to reduce the risk of the cancer coming back, and also has shown a survival benefit. So this information is key to ask about in terms of testing. A couple other words on genetic testing. In a given family, the affected individual is the most appropriate person to test for the presence of a germline mutation. Testing the affected family member first will establish if there is a detectable mutation in a known cancer risk gene, and this provides more informative testing for unaffected family members. If an affected individual tests negative, this may eliminate the need to test multiple unaffected family members and save resources. But again, this would be an individual discussion with the genetic counselor. You may still meet criteria to undergo testing. Of course, if an affected individual tests positive, this may explain the cancer history in the family and provide unaffected family members who test negative reassurance that they didn't inherit the cancer risk. So genetic testing is an important aspect of testing, especially in the early stage, but also in the metastatic setting, where guidelines indicate that all women with metastatic breast cancer should be offered genetic testing. Genetic testing guidelines have recently been changed as well, that every woman with a breast cancer diagnosis who's less than 65 should consider genetic testing. And based on other factors, individualizing treatment recommendations, or testing rather, recommendations for women over 65 with a breast cancer diagnosis is also recommended. I just want to spend a moment on talking about these terms, genetics versus genomics, because in my practice, people are confused about this constantly. So the testing that we've been talking about in terms of BRCA and the other genes I showed you in that table, that's considered germline genetic testing. Those are genes that could be mutated, that would have been inherited from a parent and could be passed on to a child. And genetics, again, is the study of individual genes and inheritance. Genomics is the study of multiple gene functions and interactions with each other and the environment. So, for example, I spoke with you about HER2. That is a genomic test on the tumor. That's a gene, but it doesn't mean that it's something that can be passed on to a family member. That is genomic testing on the tumor. ER, PR, HER2 is all genomic testing. And of course, we've moved into an era of very sophisticated genomic testing, including gene expression and next generation sequencing. And we'll talk a little bit about that more when we get involved in the discussion on metastatic disease. So just to finish up the early stage, I do want to talk about one other aspect of testing that is important, and just take a big step back and talk about, broadly speaking, the 3 different treatment decision points in the early stage hormone receptor positive breast cancer patients' journey. Now, recognize again, I'm only focusing on hormone receptor positive because it's the more common subtype. This journey may look different for a triple negative breast cancer patient and a HER2 positive breast cancer patient, and certainly tests to identify whether or not HER2 directed treatment would be, of course, recommended, and that journey and pathway may look very different as it would for a triple negative patient, where we have the use of immunotherapy and chemotherapy now routinely in the early stage setting. So again, just focusing on hormone receptor positive, in the initial diagnosis, usually surgery is done first. There are only selected cases where we consider preoperative treatment, but in the usual case, you go for surgery first. And the decision is, do you need chemotherapy and hormonal or endocrine therapy, or is endocrine therapy alone sufficient? There is also now the availability of these 2 drugs called CDK4/6 inhibitors. These are therapies that were initially approved for stage 4 metastatic patients, and now in high risk early stage breast cancer patients can be taken for either 2 or 3 years, depending on which drug is chosen. And in addition to the chemo and endocrine therapy, those drugs have shown further reductions in the risk of relapse. And then there is this time point of 5 years. Most women take hormonal therapy for 5 years. It's very important to note that over 50% or more of the recurrences actually happen after that 5-year mark. And so with that in mind, there is the opportunity to consider longer durations of hormonal therapy. So I bring up these decisions because, again, the focus of the presentation is testing. So how does that factor into testing? There are tests that can be offered. Again, these are tests on the tumor that can help us make these decisions. You may have heard of these tests, Oncotype, MammaPrint. These are tests that help us make that first decision about, does chemotherapy help reduce the risk? So they provide prognostic information, meaning what is my risk of recurrence? And some of these tests also provide predictive information. What is my benefit of taking a certain therapy, either chemotherapy or, in the case of the breast cancer index, this test can help understand what your risk is if you were to stop the endocrine therapy at 5 years, and whether there would be a benefit to continue to 10 years. And of course, there are other tests as well. So the summary of the testing in early stage breast cancer, again, I hope that I've driven these points home to you. Genomic tests, including ER, PR, and HER2, these very much guide our choice of therapy. Gene expression assays, like the ones I just showed you in the previous slide, can help make decisions about the use of chemotherapy and the duration of endocrine therapy. Again, an informed discussion regarding germline genetic testing based on a personalized risk assessment, taking into account the age at diagnosis, your specific family history, your specific type of breast cancer. These are absolutely things that should be discussed with your physician at diagnosis. So with that, I'm going to pause. We're at the halfway mark, so this is perfect timing to ask if there are any questions.
Yes, thank you, Dr. Mahtani. You did a great job, and you've actually answered a lot of the questions, and I'm going to hold the genomic testing questions. So I'm just going to ask a few on this. So one thing you didn't touch on is the Signatera test.
That's a great question. I'm glad that somebody brought that up. So this is a test that has been marketed quite a bit to patients directly. And just so that we all are on the same page in terms of what this information, how this information helps. There are fragments of tumor DNA that can be spilled into the bloodstream and can be picked up at a very low level, much more sensitive than PET scans and bone scans and CT scans. And this is a type of testing that has the promise of finding cancer when it has come back earlier than when we can see it on imaging studies. So it's a very sensitive tool, and it gives us a lot of information about prognosis, risk of recurrence, but it's not 100% accurate. That sensitivity is not 100%. So just because you have that positive signal doesn't mean there's 100% risk that the cancer will come back. Additionally, and most importantly, the part that we all are struggling with in practice is, what does it mean if it is a positive test? Does it mean that we should intervene in some sort of way? What should we intervene with? How many cycles of whatever treatment should we give? And are we actually impacting recurrences, or are we just exposing people to more therapy, more toxic treatments and side effects? So until the trials are complete and multiple studies are ongoing to test the intervention of using tests like Signatera and others, we're not routinely recommending outside the context of a clinical trial for this sort of testing to be done.
Great, that's helpful. So the name of the test is Signatera and the company is Natera. So some of the participants are using those names interchangeably, but they're the same. So there's a number of people who are, not surprisingly, struggling with side effects from either their AI or tamoxifen. So wondering, when would it make sense to maybe do the MammaPrint or the Prosigna to see if there is benefit for continuing hormonal treatment?
So the test that helps make that decision about continuing endocrine therapy to 10 years or not, the one that's been endorsed by the guidelines, is actually the breast cancer index. And typically that test is offered around year 4. Now, I should tell you that in the setting of more than 3 positive nodes, it wouldn't be appropriate to order the test. It's not been validated to support decisions in that situation. If you have more than 3 positive nodes, the recommendation is usually to extend to 10 years. But around year 4 is when I start talking to my patients about it, because it can take some time to track that tissue down and send it out to the company and for the results to come back. And, we try to make these decisions not in a rushed way. So somewhere around year 4, you could consider talking to your medical oncologist about ordering it if they feel comfortable and they feel it's appropriate.
Okay, that's helpful. And there are other companies that talk about the benefit of their test. So important to talk to your doctor about which test
Correct.
is appropriate. I think it's worth talking about this, although it might come up in the genomic testing section, is we've made a lot of progress with liquid biopsies, and it's made it a lot easier. So if you could sort of talk about that, not having to do a tissue biopsy.
So in the metastatic setting, we're going to talk about that quite a bit, because for the early stage setting, tissue biopsy is still our standard, because at the early stage diagnosis, we're talking about confirming that whatever is going on imaging or on exam is indeed breast cancer, and confirming those important markers, ER, PR, and HER2. Liquid biopsies, again, in the early stage setting, are not routinely being utilized. It's in the metastatic setting where that information is so important, because it can give us clues about possible next treatment options. And we'll talk about that in the next section.
Great. And then just to clarify for a participant, if you're HER2 positive, these tests about stopping, I'm assuming they're HER2 positive and ER positive, but I don't know. Do these tests about potentially stopping endocrine therapy apply to them?
That's a great question. So the data with some of these tests in ER positive and HER2 positive, we call that triple positive tumors. The data is not as strong to utilize these tests. About 15% or less of patients that were enrolled on trials that validated the use of tests like breast cancer index had HER2 positive and ER positive disease. That being said, the smaller data sets that we have do point to a possible role, even in ER positive, HER2 positive patients. That's an individual discussion, again, with your physician, whether he or she feels comfortable utilizing it in that way.
Great. I'm going to ask one more question and then we'll go to the next section. If you've made it to 10 years, is there any need for additional testing after that?
So recognize that even in the first 5 years after an initial diagnosis, our guidelines do not call for any routine tests to be done. And certainly the farther away that you get from that initial diagnosis, the lower chance you have of developing a recurrence. After year 5, there can be recurrences, but the farther out you get, your prognosis improves. Patients are always asking, why are we not doing testing? And the real answer is that there has never been any study that has shown us that finding metastatic disease earlier and intervening is impacting outcomes. And that's a tough conversation also when it comes to the radiation exposure and the length of scans that we would have to do for a subtype of breast cancer like ER positive breast cancer, where recurrences can happen, even 7 or 8 years out. So this is a question that we hear about quite often, or I get asked about quite often. But again, we don't recommend any routine scans after a diagnosis to monitor.
Right. And we know, I'm seeing some comments. We know that some women do recur after that, and it's really shocking. So we need to remember that. Okay, I
should just point out, I'm sorry, Jean, to interrupt. I just want to qualify what I said by saying that it's not that if you have a symptom, if you have pain, or if you have a cough or abdominal pain, absolutely imaging should be done in that situation to investigate what is going on, and that should be brought to the attention of your physician. Additionally, some of us, myself included, I do routine blood work every 6 months or so in the first couple years to monitor. And again, even that's not technically recommended. But if there are abnormalities in liver function or other tests, that could also be a reason to do imaging.
Okay, thank you. I am going to ask this one other question because I think there is some confusion. When should the Oncotype DX test be sent out? At biopsy or when you have your surgery and lymph node?
Either is appropriate. There is good, what we call concordance with a lot of these tests, MammaPrint as well as Oncotype, where they've looked at the results on the biopsy as well as on the final pathology specimen at the time of mastectomy or lumpectomy. So sometimes it is sent at the time of biopsy because the surgeon and the medical oncologist are trying to get a sense of whether that individual needs chemotherapy or not. And if they absolutely do, if there is perhaps the consideration that it may be helpful to give prior to surgery, that information could help guide that decision.
Great. So this is something, patients need to talk to their doctor about. Sounds like it could be done either time. Okay, I'm going to let you continue. Thank you.
Sure. Thank you. So now let's move on to the metastatic setting. And again, I am focusing on hormone receptor positive, HER2 negative. I am going to make sure we leave time for questions, and I have inserted some information on HER2 positive disease and triple negative as well. So I want to make sure that this is generally applicable to everybody. So for ER positive, HER2 negative metastatic breast cancer, typically a hormone therapy, and again, we're using that term interchangeably with endocrine therapy, hormonal therapy with a CDK4/6 inhibitor. This is what we call a cell cycle inhibitor. These are pills They're not chemotherapy. They're targeted treatments that inhibit the cell cycle and are utilized in conjunction with hormonal therapy. On this slide, you see types of hormonal therapy. You see the brand name and the trade name, or a generic name and the brand name shown for you. And hormonal therapy medications are typically given in conjunction with a CDK4/6 inhibitor. We have 3 approved: palbociclib, ribociclib, and abemaciclib. And it's important to remember that every individual's treatment plan is unique for them. There are certain times where we would consider endocrine therapy alone, but in my practice, I generally do start with a CDK4/6 inhibitor. So how is an initial treatment option selected? Of course, you and your care team will choose the option that's right for you, and it may depend on factors like what prior therapy did you get for early stage breast cancer. Remember, we talked about endocrine therapy, chemotherapy, CDK4/6 inhibitors in high-risk patients, extended adjuvant endocrine therapy in the early stage setting, meaning beyond 5 years, taking a longer duration. So all of those things factor in. Whether you're pre or postmenopausal can impact your choice of therapy, what side effects you're willing to tolerate, what side effects or you may have as a residual from your prior treatment, your other medical illnesses and other medicines that you may be on. Now, again, the focus is on testing for this presentation. So when we use the term biomarkers, we're again talking about tests that can be done on the tumor. So biomarkers are certain proteins, genes, or changes in the genes. We call these gene mutations that can happen in cancer cells. And this type of testing is useful to show which treatment is most likely to work for your cancer. Some cancer drugs are only effective for people with certain cancer biomarkers. I'm going to bring up the example of triple negative breast cancer here, where a stage 4 or metastatic triple negative breast cancer patient who's newly diagnosed, this biomarker PD-L1 is an important one to identify a patient who may be eligible to receive immunotherapy in combination with chemotherapy as the first treatment for stage 4 triple negative breast cancer. Again, we talked about germline genetic testing, BRCA1 and 2, for early stage disease. And I made the comment earlier, I will make it again now. If you did not undergo germline genetic testing as part of early stage testing, if you develop metastatic disease or you present with metastatic disease, we call that stage 4 de novo metastatic breast cancer, you absolutely should have germline genetic testing. There are 2 oral therapies called PARP inhibitors that are available treatment options. And there are other genes that can be mutated that we'll go through, including this gene PIK3CA. And again, this information, microsatellite instability, can impact the availability of immunotherapy as a treatment option. So I showed you that slide when we were talking about HER2 in the early stage setting, and now I want to bring up this concept of HER2 low. And there's even now HER2 ultra low, which is a more recent designation. So in the early stage setting, this information hasn't factored in yet, but I do think it will in the future. But in the metastatic setting, HER2 low has absolutely factored into treatment options because some of these tumors now are eligible to take drugs that used to be only for HER2 positive, 3+ or 2+ with what we call gene amplification. Now, if your tumor is HER2 low, either 1+ or 2+ without gene amplification, those are called HER2 low tumors. and there's an opportunity to take a drug that was previously only approved for HER2 positive breast cancer if you have HER2 low disease. We'll talk about that in a little bit more detail. So let's talk about reasons that hormonal therapy stops working. And again, that could be hormonal therapy with a CDK4/6 inhibitor or hormonal therapy alone. So we know that in the presence of our therapies, these mutations can develop and they can cause resistance to the drugs that we're giving. And resistance is when the current medication stops working and the cancer can still continue to grow despite someone being completely compliant, taking the medication as prescribed. And at that point, testing for actionable mutations may help your doctor recommend targeted treatment options. So for example, we talked about CDK4/6 inhibitors and endocrine therapy being the initial treatment. Again, several trials have investigated this as the first line treatment, and there are studies that show that taking these drugs upfront are associated with an overall survival benefit. There are also studies that have started to look at, well, if the first treatment stops working, could we switch to another CDK inhibitor or switch to a different hormonal medication and continue this class of CDK4/6 inhibitors? We think of doing this especially in people who've had really long durations of disease control on CDK4/6 inhibitors. So this is an option that can sometimes be available. For individuals who have exhausted all of our targeted treatment approaches, including CDK4/6 inhibitors and some of the other molecularly directed targeted treatments and endocrine therapy that I'll be talking to you about, antibody drug conjugates are now a type of therapy that are available. It's a very targeted delivery of chemotherapy via an antibody. This is sort of called a Trojan horse. So the chemotherapy is directed specifically to a target on the surface of the cancer cell, and the chemotherapy is directly delivered there. So trastuzumab deruxtecan is one such antibody drug conjugate. This is approved for HER2 positive breast cancer as well as HER2 low. Sacituzumab govitecan, this is approved for triple negative breast cancer as well as hormone receptor positive HER2 zero as well as HER2 low breast cancer. And trastuzumab emtansine is for HER2 positive breast cancer. So I just want to show you this common mechanism of action. I don't get intimidated by this slide. I'm going to talk you through it. It's actually pretty easy. You see the tumor cell here, and you see the drug, the antibody drug conjugate, coming with the targeted chemotherapy payload, attaching to the target, getting internalized into the cell, and then the chemotherapy falls off, and in certain cases drifts across this cell membrane and kills off neighboring cells that have some of that same target expression. This is the mechanism that we call the bystander effect, and this is why, for example, drugs like trastuzumab deruxtecan can work in HER2 low disease. And then finally, let's talk a little bit about molecularly directed targeted therapies that are designed to target specific genetic or molecular alterations in cancer cells. Olaparib on the bottom, there's another one also called talazoparib, is in that class of treatment called PARP inhibitors that are available if you have a germline BRCA1 or 2 mutation. And then there are other drugs, you see the trade name and the generic name, that are based on other mutations that I'll show to you here. So one mutation that again is tested for typically in a liquid biopsy. So this is where liquid biopsies in metastatic disease have saved a lot of women the trouble of having to go through multiple tumor biopsies. This is a blood test that can look for the presence of this mutation in the estrogen receptor. It's called the ESR1 mutation. And if that mutation is found, you could potentially be a candidate for this drug called elacestrant. Another test that can be done again in a liquid biopsy can also sometimes be done on a tissue biopsy, is for this pathway alteration in this pathway called the AKT pathway. It includes AKT, PTEN alterations, or the PIK3CA gene. And it could mean that these drugs, alpelisib or capivasertib, which target these specific mutations, given in combination with fulvestrant, may be your next best treatment options. And then again, I mentioned the BRCA mutation. This is still considered biomarker testing. It's germline genetic testing. It can also be tested for on the tumor. We call that somatic BRCA mutation testing. If you do have this mutation found in your tumor, you should go back and still have germline genetic testing as well. And olaparib, or the other PARP inhibitor that's not shown on this slide, talazoparib, are approved therapy options. So when is biomarker testing needed alongside your journey for your decisions? Well, more and more we're thinking of doing this even at first line diagnosis, because there are newer drugs that are coming, including PIK3CA inhibitors, that are showing a benefit upfront in patients that have very aggressive disease that recur within 12 months of completing early stage treatment. So knowing if you have that mutation up front may soon be very important. Typically nowadays we're testing after first line treatment, and we're looking for actionable mutations. And the key is that this type of testing can be done repetitively, because certain mutations can emerge in the presence of our treatments. And so these are discussions, again, that your medical oncologist should have with you. Again, here you see genomic testing during the breast cancer timeline, and sorry for the formatting here, but again, I've sort of tried to include this as a big picture, early stage and metastatic continuum for testing. Remember, in the early stage setting, we call our treatments adjunctive treatments, or additional treatments, so adjuvant therapy for the presence of germline mutations, for ER, PR, HER2, assays that can help make the decision about whether you need chemo or chemo and endocrine therapy, or endocrine therapy alone. At the time of first metastasis, it's always important to confirm that you're dealing with breast cancer and not another type of cancer, or not something that's completely benign and just looks suspicious on imaging. Confirm that it is cancer, confirm that ER, PR, and HER2 are the same. They can change. Again, if you haven't had germline testing in the early stage setting, it should be done in the metastatic setting. PD-L1 testing is important to understand whether or not immunotherapy would be added to chemo for triple negative breast cancer. These other mutations that I've talked about, PIK3CA, ESR1, AKT mutations, HER2 mutations, things that I didn't get a chance to talk to you about, but all of this information can be seen on a liquid biopsy. In certain instances, tissue biopsies are needed as well, but we've made a lot of progress in treating breast cancer. So I will end with two slides that just kind of are a step back, big picture view. This is a quote from a physician who was asked to chair the European Society of Medical Oncology Personalized Medicine Task Force. And he said, personalized medicine comes from the result of research efforts over the past 20 to 30 years to understand the complexity of cancer, not only between different tumor types and organs, but also within any tumor. There is enormous heterogeneity. As a result, an approach of providing the same kind of therapy to the same patients just because their tumors arise in the same organs, breast, lung, prostate, or whatever, will be effective in general, but does not work for everyone, unfortunately. So our goal is to offer personalized medicine that can be described as the right medicine for the right patient at the right time. And with that, I will take any questions.
Thank you so much, Dr. Mahtani. You covered a lot, and I think I said this last week too, it's very complicated, and we understand that as a patient, you have a lot of information to digest. So it's so important to have a medical oncologist like Dr. Mahtani who will sit with you and really help you understand. I want to just ask a general question. With all these advances in testing, are insurance companies keeping pace? Are they being paid for? What do patients need to know?
Those are great questions. And I think that in the situation where we have approved therapies that are on the basis of certain mutations, I've not had a lot of pushback. I have had some insurance companies, most of them, they ask for proof of that mutation. So when you order the test, they're looking through your medical records to make sure that you have a liquid biopsy or a pathology report, something that confirms that that mutation or protein alteration is present, which guides their coverage of your medication.
Right. Okay. So as patients, you've got to ask the questions and be advocates so you don't get surprised if you're going to be charged. One test you didn't talk about is the PET FES test. And I don't know if that's something you're comfortable sharing a little bit about.
Yeah, so I think that's a great question. There is a new type of PET scan. It's called a Sariana PET or an FES, an estrogen labeled PET scan. It uses a different radioisotope and it focuses on cancer cells that are expressing the estrogen receptor. This is a test that is being utilized more and more in cancers that are of what we call lobular subtypes, where they don't show up as well on imaging. I have started to order these FES PETs, especially in those cases. Again, some insurance pushback sometimes and a little bit more in coordination in getting the test because it's not as easily available, but it is something that has been particularly useful in my practice for lobular breast cancers.
That's great. And Living Beyond Breast Cancer did just update content on this, and we also have a blog. We're so short on time, but I do want to ask, there is a little bit of confusion from our metastatic patients that are listening and our early stage. Does MammaPrint or Oncotype apply to anyone in the metastatic setting?
So right now we're not utilizing MammaPrint or Oncotype for decisions in the metastatic setting. Those are tests that are done on the tumor to help us predict what the risk of recurrence and what the benefit of taking chemotherapy is. So in the metastatic setting, it wouldn't be indicated. Although there is a test that is accompanying the MammaPrint test, it's called Blueprint. It can sometimes be helpful. Again, in the early stage setting, there is some investigation to look to see if that sort of grouping of breast cancers in the metastatic setting may help make decisions, but it's not a routinely offered test in the metastatic setting.
Great. And Living Beyond Breast Cancer does have information on Blueprint also if you look on our website. So I think we're going to have to end. I want to tell everyone that the session last week with Dr. Teplinsky really focused more on treatments and side effects. And Dr. Mahtani touched on some of them, but if you still have questions about the role of ADCs or CDK4/6 inhibitors, please make time to watch that. I think it'll be really helpful. I think, Dr. Mahtani, I said this to Dr. Teplinsky, are you, with all these advances, if you are seeing a general oncologist that doesn't necessarily specialize in breast cancer, since LBBC serves people all over the country, what do you suggest they do to make sure they're getting the best care possible?
Well, I think, you bring up a very important point. And fortunately, a lot of even community oncologists who treat multiple tumor types are now sort of specializing within their groups. And there may be one person that does more breast cancer. As we know, breast cancer is one of the most common subtypes of cancers that medical oncologists see. So it's rare to find someone who has no breast cancer patients in their practice, which is reassuring. But I do think, again, to your point, being your own advocate and making sure that you're coming armed with a list of questions. I love it when my patients come in. They're always apologizing to me. And I say, please don't apologize. This is why I love taking care of breast cancer patients. They're so engaged and they ask me great questions. So you should feel empowered to ask your oncologist questions. And if you're getting a lot of pushback, that's where it may be a sign that it might be time to get another opinion.
That's great advice.